Hello and welcome to another Pilates Hour. It seems like today everybody wants to get emotional with their psoases, so we're going to have a great time talking about the psoas. I don't know why that muscle is so interesting to so many people. While we're waiting for everybody to come on, we have a record high number today in the registration of over 1,600 people wanting to talk about their psoas or somebody's psoas. And while we're sort of loading up and coming on, I just want to do my own little personal shout out today. Our licensee and our team in Turkey, Atkinsachi, is they're amazing. And they jumped in their van, filled it up with food and blankets and clothing and diapers and all kinds of things from Istanbul, drove over 12 hours to the earthquake site. It had been there now for 2 days, helping people, driving back a couple hours to where they can find more food and bringing it back and helping. So just asking that everybody, keep them in your prayers and your thoughts. We're going to be sending some funds their way today, hopefully allowing them to continue to help. We have a lot of people that were just in a course for Polestar in the city that was hit by the earthquake just a couple of weeks ago. So we're making sure that we have a head count and that everybody is safe and well. Well, hey, let's get started. We got a lot to talk about today. And one of the things that I have some pretty decent slides today that I put together, I must say. So I'm going to share them with you. And as the title talked about, we often put a personality on this muscle, the psoas. And so there are a lot of, I went into the yoga literature and into some of the body working literature and just found a couple sayings, a couple phrases, a couple titles of papers that are out there. The psoas relates to sexual trauma. The psoas muscle, also referred to as the muscle of the soul, holds on traumatic experiences on a cellular level. A quote from Liz Koch's book, The Psoas Book. There's books written about the psoas. It said, "It is an organ of perception composed of biointelligent tissues that embodies our deepest urge for survival." And then the last thing is there's a book called The Muscle of Emotion. It was talking about the psoas. So I can't say yay or nay to this. I mean, I think these are experiences. I think many of you maybe do a shout out in the chat if you wanted to, that if you felt that, you have felt stress and you feel it in your hip flexor area or in the abdominal area or in the hips, and that if there was if you had patients or clients that you've made this association with. I remember growing up in the dance world and being told that the psoas was this emotional muscle that we had to work through. So we're going to talk more matter of fact, and we're going to be talking about the anatomy of, and then we're going to be talking about how it actually affects our posture, our movement, our ability to accelerate, decelerate, walk, sit, the Pilates exercises we do. And I love talking about this region of the body. So let's dive right in. And the first thing we're going to look at here is the actual anatomy of the psoas. I'm going to keep my little laser pen here nice and close. But what I want to bring your attention to is this is a very complex set of muscles. There's nothing easy about this. If you think of where the iliopsoas originates from, it originates from the medial side of the femur, right, sort of in the groin. And then it goes over the pubic rami, coming in the front. And the iliacus is going to come up into the iliac crest. That's where it stops. So its motion really is pulling from this insertion to this origin. It pulls from this insertion to this origin. And what it's going to do is flex and externally rotate if you look at where the position of the leg is. But if I'm standing and I'm going into extension on that leg like a toe off, that could have a very different property of elasticity just in the iliacus. Then we look at the psoas, and the psoas is typically broken into two parts. We call the psoas major and the psoas minor. So the psoas major is this nice sort of pinkish that ties into the tendon of the iliopsoas tendon and then comes up and attaches to the front of the spine. And one point I want to bring here is this is going to be really important as we start talking about how we know if we have a problem with our hip flexors, whether it's a psoas or whether it's iliacus or whether it's a psoas minor, or maybe it's another hip flexor like the tensor fascia lata or the femoral muscles. So when I look at this, what I think of, and we're looking at it from a sagittal viewpoint, we're looking at its relationship into the spine. What we're not seeing is the curve of the spine. And so the psoas has a lot to do as well with stability of the spine. And the spine has to be stable for the psoas to work as a hip flexor. If it's not, it's just going to cause compression. It also has the tiny fibers, you'll notice here on that maybe cover 2 to 3 segments, sort of like the multifidi does in the back, that act as local stabilizers. So very interesting musculature that we are looking at here. And then if we go over to the other side, I peeled all the iliopsoas away, and we're looking at the quadratus lumborum. And the quadratus lumborum also comes all the way up through the diaphragm into the thorax onto the first or the 12th rib and T12. So we have these muscles that are going up through the pelvis and from the pelvis up into the actual torso through the diaphragm. And when we think of that, it's an amazing of how many joints it influences or impacts. Let's take a look at this side view of it. So here from the front, we can see again where the iliopsoas tendon attaches on the inside of the femur, and it's going to come across the pubic rami, across the shelf of the iliac. But now you can see this beautiful lumbar lordosis. And this beautiful lumbar lordosis is providing us with the natural curve of the spine, and we're also looking at the natural anterior inclination of the innominate or the pelvis. And that is a normal vertical orientation for us as human beings or as bipedal animals. And so in order for the psoas and the iliacus to be efficient, you'll notice also in the back here, there's the piriformis. It sort of attaches in the similar area. It's going to attach onto the greater trochanter, and it's going to be controlling the external rotation or controlling the internal rotation, just opposite of the iliopsoas tendon. So they're sort of doing this on the femur. And if I brought an example of the femur up here in front of me, and I put it this way towards you, so we know that the iliopsoas is going to attach here, and we know that the piriformis is going to attach here on the trochanter. So they're responsible for the rotation and controlling a lot of that rotation in the hip. And a lot of times we don't think of it, but that iliopsoas tendon can act like an internal rotator on the femur or a decelerator of external rotation. So I love looking at these and just thinking of relationships. Again, look how high up the psoas major goes, up into T12, into the anterior body. So if you thought that you were doing a Pilates exercise where you're laying on your back, let's say, and you had to do scissors or hundreds or rollover, the question is what has to be stable for the psoas to be able to contract and actually move the femur and the lower pelvis in a flex position, or to stabilize it to be able to lift up the leg. If the lumbar spine is not in a stable orientation, right, or a stable state, then the hip flexor is just going to draw and cause an anterior shear force. It's going to cause the lumbar spine to move in this direction, right? So it's going to cause a hyperlordosis. So this is where this idea of sitting becomes such a problem, because if we're sitting all day, what muscles are in a shortened state? Well, obviously the iliopsoas is in a shortened state from sitting all day. If we go back to Dr. Carol Davis's lecture a couple weeks ago, we were talking about how the fascial system is sort of like a 3D printer. So that fascia is always sort of changing its relationship. And if we do myofascial release, we put a pressure that also changes that relationship. So we are what we do, basically. So if we sit all day and this muscle becomes relatively short, and then we try to stand up and be the bipedal animal, it's going to result again in this strong anterior kind of shear force or collapse of the lumbar spine, because what's happening here is that the top portions or insertions of that muscle are pulling down in this direction. And when that momentum or that fulcrum or that particular load point, it's going to cause compression through the lordosis. So that's why you'll see people with an anterior tilt, hyperlordosis, and wonder why their hip and their hip tendons are hurting so bad. But if you just go back a little bit, you could look and say, well, now it sort of makes sense why my back and hips would hurt so bad, is I don't have a good relationship between the pelvis and between the lumbar spine. Instead, I'm sort of collapsing that area, and gravity and the muscle force is causing compression. It's causing dysfunction there. Let's take a look at a couple other muscles here. So here we have another look at some of the muscles that also are hip flexors. So the rectus femoris, the sartorius muscle, the rectus femoris muscle also cross the hip joint. So they are indeed hip flexors. And you'll see people that have an imbalance, and this was me dancing and other things, where my tensor fascia lata was the dominant hip flexor. And you'll see people just like bulging TFLs that are in their hips. And that's because that becomes their primary mover for hip flexion. We see this all the time in Pilates and other types of abdominal exercises. In the gym, we see people over-recruiting tensor fascia lata, not having good stabilization of the trunk and not using the iliopsoas muscle correctly. And so they tend to have other problems with it. I also have this picture here looking at how that iliopsoas tendon comes in and attaches on that medial, almost posterior aspect of the femur. And you can imagine when that muscle contracts in certain positions of the leg, it's going to be a little bit different. So if I'm in a deep squat, it could actually be helping me to externally rotate if I was in a deep squat. But if I was standing, it could actually cause a little bit of internal rotation. So it's a little bit different in different positions. So I want to make that a clear statement as well, that we see this relationship change of the psoas to the femur depending on the position of the femur to the pelvis. And we'll talk a little bit more about that as we get into some positioning. The last slide I have up here is an MRI. Now, this is a tendinosis of the iliopsoas tendon. So we're talking about the tendon comes in, it attaches here. Here's the head of the femur. This is the pelvis. And this is the iliopsoas muscle coming up into the pelvis. And right here, we have this increased uptake that represents fluid or inflammation or a tendinopathy of the iliopsoas tendon. You can sort of see the fibers coming down, attaching onto the bone here, the inflammation here over the head. This is what you would typically get. If it gets too fat and too inflamed, you're going to get snapping hip, right? So that's where you move your hip and that tendon clunks over the ball or the head of the femur. And so we see that quite often in the dance world. You have an extreme range of motion. You have an irritated tendon of the iliopsoas, and it often can cause that sort of popping or cracking sound that people get. I have two quick questions here. One, we're going to get into the diaphragm in just a second. The next slide, we go into that. So I'll announce that information to the anonymous attendee. And then Joanne Coverly said, what percentage should each of the hip flexors have in relationship to others? And that's a great question. I don't think that I'm equipped to give that answer today, Joanne, but I would say that, you know, what we always say in Polestar is as much as necessary, as little as possible. So anytime there is an excessive stress on a tissue or not enough stress on another tissue, we're going to find imbalances. So what I tend to look at is if I have really good dynamic posture in my activity, then I'm probably creating the proper load on the tissues. It's when we lose that dynamic mobility that we start compensating. And that's why the sitting is such a big part of this discussion for the hip flexors, is that as we sit, I mean, the average person right now is sitting 13 hours a day. They are sleeping an average of 6-7 hours a day. That leaves very little time for movement. If you're looking at We Are What We Practice, 3 Pilates classes a week is not going to balance out the imbalances of sitting. Sitting is going to dominate those tissues. So we have to find ways throughout the week and throughout the day for us to be able to address those issues. Let's jump right into the question that came up regarding the diaphragm. So here is an inferior look at the diaphragm. So just to give you a frame of mind, this is the lumbar spine, looking at it from the bottom up. We're looking at the dome of the diaphragm going up into the thoracic cage. And the point that I want to bring here is this little muscle, you'll see a little muscle here. That muscle right here is the psoas going up through the diaphragm. And this muscle here is the quadratus lumborum going through the diaphragm. Now, what's important about that? Well, both of them are crossing over into the thoracic cage, and they also come down onto the pelvis. So when you think of the ability to maintain some level of control and stability here on the anterior spine, these have a great impact on that. You also notice these are called the cruces of the diaphragm that come down as low as L5, S1. It's continuous with the anterior longitudinal ligament that goes down to the coccyx and then makes up the fascial tissue of the pelvic floor. So when we look at the pelvic floor, that same tissue that's coming down from the thorax, from the diaphragm, is coming down in the front of the spine into the coccyx and then contributing to the fascial connection all the way to the pubic rami through the pubococcygeus muscle. So the reason why I bring this up is because if we understand the anatomy of this area, we can start understanding how dynamic and integrated it is. Like, you can't think, if I told everybody, hey, do a volitional contraction of your right piriformis right now, the likelihood of being able to do that is pretty slim and none. Even though you know it's an external rotator, you know what it does, but that's not how we work. We work off of function. So do we have awareness of our body being erect? Do we have awareness of our pelvis being on top of our femurs? You know, a lot of times when our clients are done with their Pilates session, they go like, I feel so light. I'll repeat that. I feel so light. What light represents is that the pelvis is on top of the femur and the torso is on top of the pelvis. We feel heavy, think about it from a physics standpoint, when the rib cage is anterior and the pelvis is posterior and the femur is forward, we're going to feel heavy. Heavy because our muscles and our tissues are not working efficiently on the bony structure that is there for us as bipedal animals. When the pelvis sits better on top of the femur and the spine sits better on top of the sacrum and the rib cage sits better on top of that, we often refer to this in Pilates, particularly Polestar, as those three tubes that are aligned, keeping that volume equal between the three vertical tubes. We feel lighter. That goes back to that first question that was about what percentage of, say, the tensor fascia lata versus the iliacus versus the iliopsoas versus the rectus femoris. I can't tell you that because it's going to be different for every person based on the activities we choose to perform. So a ballet dancer is going to have a very different demand on their iliopsoas than, say, a soccer player, even though they both have very big demands on their hip flexors in their sport. All right, so let's go through a couple other muscles here. Here we can see some muscles from the hip rotator, so the piriformis, the ischiococcygeus, the pubococcygeus. We also have you can see the puborectalis in the back. And also, if we palpate in here, we're going to see the obturator internus and externus that are also rotators of the hip. So a lot of things that are sort of part around this pelvis that are contributing to the stability and control of the pelvic femur relationship. And that's really what we're talking about here, is like, how do we get to that state of being light? How do we get to that place? How do we find that dynamic alignment that allows us to be balanced, to feel fluid, to feel power, right? To feel elasticity. And we know that when the fascial system, the myofascial system, which is everything, all of our connections, when the skeleton is aligned within the fascial system, we have elasticity, right? I'll say that again. When the skeletal system is aligned within the fascial system, even though the skeleton is crystallized fascia, as we know, we feel elastic, we feel light, right? We become more of an elastic animal. Remember what Dr. Davis talked about that was sort of, earth-shattering for me, was that idea that the muscle fiber, that sort of actin-myosin filament theory, was actually just creating tension inside of the myofascial tissue, the fascial tissue. And that's what generated either the increased tension to accelerate or decelerate, or for the springiness that we have in our body. And I thought that was pretty mind-blowing. Rather than thinking of the whole thing shortening, it was more about the tension that it created inside of the fascial system. And I think that's worth investigating a lot more and seeing what that's like. Let's go to another muscle group that's super important in relationship to the iliopsoas, and that's going to be the anterior abdominal wall and the lateral abdominal wall. Now, again, I love this cross-section from Netter. Here is the rectus abdominis, which is the anterior anchor between the rib cage and the pubic symphysis, right? So its direction of contraction is going to be shortening the front of the torso, or bringing the rib cage closer to the pubic bone. And then we have 3 layers of muscles that are wrapping around us. Now, we know the outer layer is the external oblique, and that has a diagonal coming in like your hands in your pocket. And that's also going to bring the rib cage closer to the front. It can help close the rib cage in the front. We'll see why that's important in a little bit. The obturator internus pulls the rib cage towards the back. So the anterior rib cage is pulled towards the back or towards the thoracolumbar fascia and connects all the way around. And then the deepest layer is the transverse abdominis. It gets so much publicity, even a lot more in the early 2000s. But it's responsible for connecting the fascia sheaths of the rectus as well as the rectus sheath of the erecti in the back. So it's connecting the front to back. So creating this tubal kind of space becomes incredibly important to how efficient the upper part of the psoas is in its function. If we don't have the control in the upper, then we're going to have inefficiency of the psoas major. If we don't have control of the femur and the hip and the pelvis alignment, we're going to have problems with the insertion or the distal part of the iliopsoas tendon, like the tendinopathies. And so we have to decide, is this really a problem of having to always stretch or have released these tissues, or is it about trying to exercise and move in a way that we're balancing that dynamic alignment, that those tissues are able to work effectively, powerfully, elastically, that we feel light and springy without the pain that is so often accompanying us these days, especially in our sedentarism. So again, just reiterating, these circles in the middle, that is a vertical cut or a horizontal cut across a vertical muscle of the rectus abdominis. In the front, we have the the external oblique, internal oblique, and the transverse abdominis, all working to connect us. And I could take it a step further and show the posterior part of it, which would be the erector spinae, and looking at the multifidi and interosseous muscles around the spine that also help to maintain that tubal kind of connectivity. How much? Enough. Right? How much? I can't tell you exactly how much. We know that in Paul Hodges' study, it was somewhere under 30% volitional contraction or maximum voluntary contraction, and it was subconscious, subvolitional. So when it's working correctly, we probably aren't feeling it, other than we feel light. That's sort of the key, right? I'm going to say it over and over again. When we are working with our clients and they say they feel light, you did the right thing. You are facilitating the right orientation of that pelvis on top of the femur. And then we could go all the way down the kinetic chain to the foot and the toes. Let's take a look at another aspect of this that I think is really important. This is another picture that I just absolutely adore. This is a cutaway of the thoracic. So up here is the head and neck, and then we come down. This is a cutaway. So the lung and the heart have been removed. It's like cutting somebody in half. And here we have the dome of the diaphragm. But what I want you to pay attention to are this green strip here coming down are the ganglia of the sympathetic nervous system. Okay, really important. And they go all the way down to like L1, L2. And they're responsible for that fight-flight response. To show you something in the next picture that might go, no wonder why there could be an emotional connection. I'm not saying there is or there isn't, but it certainly would lend itself to think of why the way the organs are set up, the way the sympathetic nervous system is set up, that psoas muscle could be so deeply linked to the sympathetic nervous system. So again, think of this coming down the front of the thoracic spine, the thoracocostal joints, and then we go one more level down, and this again is probably my favorite picture or view of torso musculature, an anterior cutaway, because here we get to see everything. But even here, if you look closely, you can see a little bit of that sympathetic chain coming down in the lowest part of the thoracic and uppermost part of the lumbar. So here we can see all of these muscles working together. Here's the diaphragm. Here are the cruces of the diaphragm I talked about that come into that anterior longitudinal ligament that go all the way down. Beautiful depiction to the coccyx and the pubococcygeus to the pubic bone. We have the quadratus lumborum going from the iliac crest up to like T12 through the diaphragm on both sides. And we have the psoas major and minor going through the diaphragm, as well as connecting to the iliacus tendon all the way down to the medial aspect of the femur. Just a beautiful way of thinking of this and thinking like, well, how do I get that portion of the structure, that pelvis in relationship to lumbar, in relationship to thoracic on top of my femur to be in its optimal position so that these muscles are getting their optimal load, right? That optimal load. How much is optimal? As much as necessary for that particular activity. Getting really strong hip flexors doesn't necessarily mean that you're going to be a better soccer player or you're going to kick the ball harder. I read a study just yesterday that the whole study was looking at strengthening the hip flexors and trying to correlate it with being a better soccer player. Well, I'm sorry, that's a ridiculous study because having strong hip flexors doesn't make you a great soccer player. Practicing and having skill set as a soccer player and having efficiency and mobility and agility and knowing the game make you a great soccer player. And practicing how you're going to do that make you a great soccer player. What's going to happen to great soccer players? Their psoas is going to get strong because they're using it, because it's part of their agility, the way that they move. So I think it's important to get away from thinking like, oh, I'm going to strengthen this muscle or I'm going to relax this muscle, or I'm going to stretch this muscle so that I can perform better, rather than thinking, let's perform better so that these muscles can respond appropriately to the activity we want to participate in. There's a question that came in from Christine LaRoque that says, having a snapping hip syndrome, you need to stretch your psoas and piriformis as a question. We're going to talk about that because we're going to go through and try to identify what really is the problem, what really is causing the inflammation of the iliopsoas tendon. And I think when we understand that, then we're more likely to understand what the treatment would be, right? Because it could be that if the pelvis is not in a very good position for that activity, that there's too much stress on the iliopsoas tendon. So stretching the iliopsoas tendon is not going to solve the problem of poor alignment. Or maybe there is a weakness that exists. There are certain things. I was reading some other literature yesterday that was looking at how the size of the psoas is indicative of cancer and abdominal and peritoneum problems and life expectancy. That they can take a look at the size of the psoas and predict life expectancy, and it had a high correlation. So there is something probably tied into being active, is what I would assume. People who are sick and start to deteriorate or not walking or not being active and doing activities and hiking, they're more likely to have, earlier death or more severe symptoms with the disease. I don't think it's that the psoas is the soul of the body, and when it dwindles, you're going to die. I think it's more that when you're sick, you are not active, and when you're not active, these muscles are going to dwindle away. I hope that answers that question. Let's take a look at an MRI. So here we have an MRI, and again, this is a nice depiction with contrast of looking at the right and the left psoas major coming up into the spine. But what I want you to realize is that we have so many spine anomalies. Lisa Stoltz and Hagit have a beautiful course getting ready to come out with Polestar. That's the new updated version of the spine anomalies and scoliosis course. So get ready for that. But a little rotation of the spine could actually make some of these muscles less efficient. This little rotation here at T12L1 could make that hip flexor maybe less engageable with normal load. some of the pelvic torsions, some of the leg length discrepancies, things that we see all the time, minor changes could potentially put one side at an inequilibrium or a disadvantage compared to the other side. So I just thought this was a great slide to, give you an idea of even the thickness. It doesn't look as thick as on the left. Well, that could be just from the pure rotation of those vertebrae in the lumbar spine. All right. This is some exciting stuff here, right? So when we think of this idea of how do I get the pelvis to be in the right position on top of the femur and the back to be in the right position, these are two exaggerated positions. On the left, we have an anterior tilt. So you can see how an anterior tilt, the innominate or the pelvic half is rotated forward. That's going to also rotate the sacrum forward, or it's going to incline it. It's called nutation of the sacrum. The position of the sacrum determines the extent of the lordosis. So in this case, it is a hyperlordosis. So what are we missing here? Why don't you just write some things into your chat session? What, in this anterior tilt, if you wanted to try to balance out this force that is rotating the pelvis forward and causing the lumbar spine to go into an anterior shear, what's missing on this back side? What's not working? Why aren't we in this? There's two things that could be happening. What do you think's going on? So I see Hugh, correct, glute weakness, right? So hip extensors, yep, glute strength, glute weakness, hamstrings as well, right? Hamstrings are going to be part of that posterior rotation. What else needs to happen? The lumbar is compressed, yep. So we want to get rid of that lumbar compression. So we want to get hip extension, a little bit of lumbar extension, right? A little vertical extension. Where do we get this force from here to help lift the torso up above the pelvis? Somebody just wrote it. Brian, thank you, sir. My buddy from here in North Carolina and my physical therapist who has done rehab on me multiple times. Thank you, Brian. The anterior abdominal wall, right? So the anterior abdominal wall is going to connect the rib cage to the pelvis and provide a little bit of a lift in the front, right? It's going to bring this space up. Hamstrings, glutes going to bring this down. We're going to see this cam right here move forward a little bit. So now let's look at the next portion of this slide where they're in an excessive posterior tilt, right? So now the glutes or the hamstrings might be dominant, right? And there's not, and maybe even the abdominals in front are dominant. They've gone too far, those anterior abdominals. And now we're in a posterior tilt. So now the pelvis is too far back, right? And this is where you're going to see a lot of things like the snapping hip tendons, right? Because this is a typical sort of balletic position. The ballet dancers for centuries now have been told to tuck their bottom under, to push their pelvis forward. Well, that takes that femur. I did happen to bring some bones with me today, but it takes that femur and it's going to push it forward because it's tucked under. So when that bone comes forward, that tendon that comes up over that bone is going to snap, especially when you have excessive ranges of motion that would go up into, posse developpe to the side of the head. So when we're looking at those things, we see that just little tiny shifts. So what would you think of trying to find the balance between these two extremes of the pelvic femur relationship? How do we go there, right? And again, which one do you think is more associated with prolonged sitting? The one on the left or the one on the right? It's a trick question. It depends how you sit, right? So if you're sitting in a chair and a desk where you're tilting forward, you're going to look more like this. If you're sitting in a couch or a sofa where you sink into it in the back, you're going to look more posteriorly tilted. They both have their disadvantages, right? So it's just, again, being able to think like, how do I get my rib cage right on top of my pelvis when I'm sitting? How do I get it on top of my pelvis when I'm standing? Well, the psoas muscle is involved in both of those, right? It's involved in both. So what happens if my psoas tissues are shorter down in this range towards the insertion? It's probably going to be more like an anterior tilt. What happens if they're shorter up here in the upper part towards the spine? It's going to be more of a shear force in the spine. So how do we get to those areas? How do we lengthen them? How do we get strength around the structure to be able to create that axial elongation that we talk about so much? Let's change positions. Let's go into a very common position. This is Shelley doing the 100 pose. And I wrote a little script here on top of so I wouldn't forget. But I wanted to, a lot of times when we're teaching any kind of supine leg exercise, right? Single knee stretch, double leg stretch, knees to chest, 100, rollover, scissors, all of those things, hip circles. We're looking at how do we, these are strong hip flexor exercises. How do we get the spine in its optimal position so that the hip flexor can be used in its entirety instead of just a little bit of it or being in an actively insufficient range of motion? So actively insufficient means the muscle's too short to do anything. If I contract my bicep all the way up here, I don't have a lot of strength in my resistance here, but when I let it out to 45, 90 degrees, now I have power, right? So this is the same thing with the hip flexor. So by rolling up the thoracic spine to the base of the scapula, what we've actually done is we've created a natural stability of that thoracolumbar junction where that psoas originates from. And when that happens, then the hip flexor that comes down into the hip and the femur is going to be much more effective. You see it all the time. Somebody that lets their back come up or they arch while they're trying to do leg circles has a horrible time, often will deal with some discomfort and pain. The same thing if they do an active posterior tilt where they're literally pressing their low back flat. There's not a whole lot of difference between that, right, and flattening your back. Where here, what we're doing is we're rolling the thoracic spine up just to a base point that it creates an elongation tension on the lumbar spine, and it anchors where that origin of the psoas is going to connect at T12, L1, L2, L3 to be able to have a much more effective strength and power of that hip flexor. It's pretty impressive, the difference of it. If we take a look at the musculoskeletal version of it, here we go. So you notice I drew a little arrow of what has to happen is that there has to be a force that is going down to be able to resist the force that's going to be pulling on these up over this sort of fulcrum here of the pelvis. And some people tell people flatten their back or imprint their back. And what we're saying is if we get the proper thoracic rotation or flexion up to the base of the shoulder blade, we're probably going to have ample control. We can still breathe, which is required of this exercise, and feel very strong in the hip flexors. So we're going to move into the exciting part now of how do we identify the impairment? So we're specifically talking about the hip flexor today of the psoas major and minor and the iliacus, right? So we're talking about these three muscles that are combined together in their insertion on the hip or the femur. So when we look at this, we can come back to our Polestar principles of movement. We can identify where is that impairment? Is it how did they lose that alignment, right? So we said it could be an anterior tilt of the pelvis. It could be a posterior tilt of the pelvis. It could be externally rotated femurs or a wide base of support. There's lots of different variations of normal. But when we realize it, look, they could have a more effective alignment around their pelvis and their hip. Then we can ask the question, is this a coordination deficiency? Right? Like if I just told them what to do or I gave them a tactile cue or I position their pelvis in the right place, would they all of a sudden have it and go, oh, that feels so much better, right? That happens a lot of times. Is it a breath deficiency? We found that people that don't know how to diaphragmatically breathe or to do circumferential breathing and narrowing, that they often have a very hard time with controlling movement that requires hip flexion. We also know that there could just be weakness around the torso or weakness imbalance of the hamstrings or the glutes or the opposing muscles, the antagonist muscles, to be able to create that balance so that we could get the synergy, right? The synergy is when they work together to be able to have a stronger hip flexor against gravity. And then the last one is mobility. So mobility could be that maybe the myofascial tissue is now restricted. It could be that the joint of the hip is restricted. This happens quite often is in degeneration of the coxofemoral joint or the hip joint, that the tendons are working overtime trying to protect or stabilize around it when it doesn't move so well. Or opposite of that, if you've had a labrum removed and you have excessive movement inside the hip joint, the tendons will work overtime as well. And so we start seeing these imbalances that could be a result of true lack of mobility in the hip or in the pelvis or post-fusion of the spine, those kind of things that we need to address as well. So again, just thinking of how we address these. Coordination, we teach, we facilitate. Breath, we can teach and facilitate. We also know that we have a lot of great exercises and tools in the Pilates environment to be able to facilitate breath in all three dimensions: superior, inferior, anterior, posterior, and lateral. And when somebody has good control, and we measure this in our Polestar assessment tool, we look at the circumference around the rib cage. And when you inhale, it opens up how much? Well, we'd like to see at least 2 inches. And when you exhale from that resting place, we want to see another 1.5 to 2 inches. If you have that kind of displacement, then your breathing can provide incredible stability and control around the torso without even having to think of contracting a muscle. Then we come down to control, and control is going to be literally, we create assistive environments to start strengthening and conditioning this relationship, this neuromuscular relationship around the torso, around the pelvis, to be more effective, right? To be more efficient, so that we're recruiting as much as necessary, as little as possible, to execute that movement. And the last one is, if there really is a mobility restriction, then we could do things like teaching them how to do proper stretching, how to do myofascial release balls and tools, to receive therapy, going to a body worker or a therapist that does myofascial release to that area. And again, remembering that any of these restrictions or strength limitations could be down in the insertion, down by the femur and in the groin, or it could be in the iliacus, in the iliac crest, or it can be up into the abdomen, all the way up to the diaphragm at T12. So that restriction could be anywhere along that way. That deficiency, that weakness, that lack of breath, that lack of control could affect you anywhere along that range of motion, could affect you in your function. All right, so let's ask some questions here. So let's say that a couple common dynamic alignment issues that we see based on sitting, prolonged sitting, and the relationship it has with the hip flexors is we see a hyperlordosis. We could see a flared rib cage. We could see an anterior pelvic tilt or a posterior pelvic tilt. And I forgot to put a flat back or hypolordosis, right? So the posterior pelvic tilt would go with a hypolordosis, a flat back. And it used to be that people thought the flat back was what we wanted. That was Joseph Pilates himself was caught on a number of occasions facilitating and wanting a flat spine. But we know better than that. We know that we need to have lumbar lordosis to be truly healthy in the back. But what Joseph was seeing in those days too was a lot of people wearing heels and hiking and climbing, that they had an anterior tilt and an increased lordotic curve, almost like a military posture. And so it was trying to get them to come back towards a midline. I think that's how I accept that. So we asked the question, which of the principles of movement are contributing to the loss of alignment and even performance? Okay, that's the question. And I think this is where we all start. We look at somebody moving and we're going like, there's just something in their dynamic alignment that does not seem so efficient, especially if they're complaining of symptoms or weakness or tendon problems, etc., or back problems. So we use our model. I don't think this is the first time I've shared this model with you, but we ask the question, is there a dynamic issue? Yes, there's an anterior pelvic tilt. There's an increased lumbar lordosis. Are there symptoms that accompany it? Yes, no. If yes, what are they? Oh, I have back pain. I have some radiating pain. My groin hurts. My hip hurts, et cetera, et cetera. We then look at the first question, is what corrects the alignment, right? If we think that the dynamic alignment is skewed, is not appropriate, then we ask the question, what will correct that alignment, right? So now we could look and say, well, does cueing awareness improve the alignment? Which would tell us that there is no modification needed necessarily. They have the facility to do this. I think this is about 60% of the time with my clients. They have a beautiful facility. They just don't have good body awareness. Our job is to bring body awareness to them. And so our cueing could then, tactile or verbal, could be what facilitates that new awareness. If we look at modification, we're probably going to modify things like range of motion or modify load. Load would be an example of control. Range of motion would be an example of mobility. And cueing awareness would be an example of coordination. So we keep working our way down this model. If they respond and they improve their awareness and they have that beautiful saying, oh, I feel so light. I feel so connected. I feel my feet on the floor. Then, and you did that with a Pilates session, that means that they're in this area here. You increase their awareness. You increase their coordination and their consciousness. And that's what they need. That's the prescription. Keep doing this. Keep taking your Pilates classes. Keep, bringing more and more awareness to your body. And we ask our clients, what do you feel in this position? What happens if you tilt your pelvis a little bit forward, a little bit back, like Shelley teaches? What do you feel? Oh, that feels more work, or that feels uncomfortable in my back. Okay, tilt it a little bit forward. What do you feel there? That feels really good. I feel powerful there. Great. That is your alignment, right, for today. If that doesn't work, right? So we sit there and we go, sorry, it doesn't work. We couldn't cue them into a better position. Something else is going on. I then go over to load. And I try to modify the load. So we can do this wonderfully in the Pilates environment, right? We can add springs. We can provide other types of assistance to minimize the load. And we can see if they can correct their alignment, their dynamic alignment with assistance. So we see this all the time in squats. They can't squat down or sit in a chair, but you give them a couple springs. Now they can sit just fine. They have the mobility. They didn't have the power or the control to withstand the load, right? So that would be a control issue. How do we treat that? Graded load. So we're going to take that person that has that malalignment of the pelvis or the back, and we're going to work with them in the Pilates equipment with modified load and gradually decrease the modification until they can handle the full load and do the full dynamic movement without any assistance. And then the last one, that leaves mobility, right? Now, sometimes mobility is limited by belief or fear or pain. They might have the movement, but they can't access it because of history or because of belief. But it could also be of true structural restrictions, right? A lot of times it is. I would say like 30, 40% of the time, we're dealing with mobility. But mobility in and of itself as a manual therapy does not fall within the scope of a Pilates teacher. So what does? Well, we can be working on stretching and moving, and I like to do more dynamic, where I think of strength and mobility through a range of motion provide power and flexibility or range of motion as a result, without having to do passive stretching or isolated strengthening. We work with the whole body, and the whole body moving is going to increase their mobility. If that still doesn't work, we refer out to somebody who has the tools to do a myofascial release, or to do dry needling, or to do oriental medicine on it, and to do some shallow needling on the iliacus. I had that done by Bob Turner. It was a life changer for me. I'd had so much scar tissue around my iliacus, and I just was always tied up in the front. And one day, Bob Turner from New York, and a lot of you know Kim Gibalisco from New York, it's her husband, the beautiful pair, beautiful teachers, beautiful movers. And Bob had studied Oriental medicine and acupuncture as well as dry needling. And I can tell you, I had an out-of-body experience when he hit that with a needle. I felt like I was out of the body looking down, and I could see myself squirming all over the place. But instantly, I felt this huge release in there, and it served me for a matter of a couple of years even, because no matter how much I had myofascial release or manipulation, just couldn't get to it. But that needle therapy was godsend for me. So again, it got to the point where it was really structural. And eventually, the hip was so bad I had to have it replaced. You know that story already. So giving you the idea, this is a great way to work through all of our problems, whatever they are with our clients. We're looking at, it's like, can they move naturally and fluidly through that activity they want to participate in? No. Let's see if we can cue them to move correctly. If they can, we just keep cueing them, keep teaching them, keep giving them the experience. If they can't, let's modify the load. And if modifying the load and the cueing doesn't change it, then we're probably looking at a mobility issue that we have to be a little more patient with and possibly refer out. I hope that helps. So here we look at possible interventions of each of these principles. So I put breath up on top, and especially for psoas kind of things and pelvic floor issues, I think we're going to see more and more breath being the solution to, hypertonic pelvic floor, stress incontinence. I think we're going to see it more important for back pain and solving different types of pelvic injuries and hip injuries. But diaphragmatic breathing, rib expansion and narrowing breath, axial elongation breath techniques, breath facilitating the exercise into the restriction and connection of that breath, right? The next one is coordination deficiencies. We use cueing all the time. We become masterful cueing. I've heard some of your cueing before, and it's so beautiful. And it really creates the image that a client or a patient can adopt and can be able to move through successfully, right? And if they can, then you know that it's a coordination issue. And I think most of our clients are, 60% fall into this coordination area. A little bit of breath training, a little bit of coordination training. And then there's a percentage that just really do not have either the neuromuscular activity to be strong enough, or they don't have the power, right? And we need to give them that power. So the way we do that is graded load that progresses back to normal load. Very simple. In this case, we're looking at strengthening trunk muscles, hip extensor muscles, adductors, abductors, any of these rotators, to be able to get them strong enough. And we know that the majority of knee injuries, this is going back to Christopher Powers' work in the knee, most of the knee pathologies we have also come from sedentaryism, in the fact that we are weak in the hip abductors and hip rotators, and therefore the bulk of the torsion and torque end up going through the knee. And that's why we see so much knee pathology, where if we were stronger in the hip and stronger in not sitting all the time, that we would have less knee pathology. It almost seems counterintuitive. Mobility deficiencies, we're looking at this idea of active release. A lot of you do this. You can, just by creating movement and stress in the opposite direction creates a reciprocal inhibition of that hip flexor. So great exercises like scooter and knee stretch and swan, all of these, doing single leg kick and heel kick and double leg kick, those all release actively the hip flexors, depending where they're at, right? And then we also look at things like true stretching. There's a couple studies that I pulled up that when you stretch for around 120 seconds, you get your optimal release of that tissue. The question is, you could do a passive stretch and you could release that psoas, but if you don't reorganize the strategy in our body of that alignment and relationship between torso, pelvis, and femur, that problem's going to come right back. You sit down for another 13 hours, and whatever you stretch and release, I can guarantee you the sitting is going to dominate. And I feel it every day, right, that we sit. All right, I have a comment and question here from Sarah. Hello, Sarah. Hope you're doing well in the UK. It says, can you comment on advising working with clients who are overweight but working on losing weight? Obviously, their mobility and alignment coordination will vary over time. And I think here it's really important to understand that I've always been surprised by people who are dealing with obesity. Of a lot of them have incredible mobility and incredible control, and they just have a weight problem, right? They move very well, and I think we have to be very careful of that sense. But from the standpoint of the load, is what concerns me, is when we're carrying a lot of extra weight, and depending where that weight is being carried, everybody's a little bit different, that can create some of those imbalances as to how the pelvis and the pelvic musculature and the hip flexors are going to be loaded. So if there's a lot of weight and it's more belly fat versus maybe thigh fat or back fat, could have a very different influence of the stressors of the psoas, the hip flexors, the spine, etc. So again, just bringing it back in, it's going to be individualized. Obesity in no way determines mobility. Matter of fact, there's a lot of very mobile people, great dancers. You see them all the time in different capacities that move beautifully that are significantly obese. And I see people that have beautiful bodies that cannot move worth beans and they have no mobility. So I think you've got to be careful of that relationship. Hani Maslik said, what is the instruction you give to the pelvic floor? Which cueing you use? Now, that's, Hani, I talk a lot about this. I'm not going to talk about it today, but I'll come back. And there are some past, I've probably done 2 or 3 webinars talking specifically about pelvic floor cueing. We know that volitional cueing is not effective. When we looked at the test and measures using real-time ultrasound, 45% of skilled female Pilates teachers were not able to actively contract their pelvic floor. But when they breathed correctly, they had a diaphragmatic breath, or they had a spontaneous movement like sit to stand, over 90% had a normal response. So for me, I love the OOV. I love doing breath cueing. I think that getting the rib cage mobile, the thoracic mobile, getting hip extension, working on the strengthening of the hip extensors and abductors, adductors, rotators is going to give you the best outcome of these type of things, even with pelvic floor dysfunction. And of course, if there's something serious like a prolapse or severe flaccidity, that's a little bit different story. That's going to need some therapy, just like Pam Downey, one of my dear friends and colleagues, who's a master working with dysfunctional pelvic floors, and that's where I send all my patients in Miami to see her when it's something that has to do with a more severe pathology. But stress incontinence that is due to hypertonicity, the best treatment is breathing, OOV, Pilates, aligning the pelvis, deep squats, really relaxing that pelvic floor. It's sort of that active insufficiency again, where the pelvic floor muscle's up so tight that it can't do its job and be proficient. Let's finish up. I got 2 more slides that I want to share with you. And I want to show you, this is a very common exercise for hip flexion stretch, but I wanted to show you and ask you, more than show you, I want to ask you, what's wrong? I've drawn some lines on here already because I don't want to try to draw them while we're in live. I don't do so well with that. But what is wrong with this picture? It's a very common yoga stretch for quads and hip flexors. What's wrong with this picture? So somebody, Daisy, said anterior tilt. Yep. What else is going on? She's an anterior tilt. Should be pushing forward. Got it. I see some needs for abdominals right here in front, right? Anterior tilt and lordosis. So what we can see here, and I hope it's big enough for you to see, but if I follow the vector of the pelvis and the spine, the hip really isn't in extension, is it? What's happened now is it has gone into the low back, and we see the low back gets, the overflow on everything of shoulders and hips. That's why we have so much low back pathology in our world. If we raise our hands up over our head, instead of getting extension from our thoracic, we drop right down the low back. When we push our legs off and we go into extension with our hip, we don't have the hip extension, so the pelvis goes into your tilt, and we create this shear force in our back. And we see that over and over again. She also has flared ribs here in front. So how would we correct this? What could we tell her? The first thing that I would do is tell her, ease up on the load on the knee. She doesn't need to be pulling that knee, the foot all the way up to the buttocks. She doesn't have that range of motion. And then to push back with her right leg a little bit and use breathing to engage that anterior wall and see if we can get a little better alignment here without this extreme stress here, right? It's not a bad stretch. I do this stretch all the time, but here's an example mechanically of what we'd like to see, right? We'd like to see that pelvis coming forward, not in a flex position. And then we load from the back to be able to get that stretch on it. and we're pulling up in a nice axially elongated position, the rib cage being connected here in front. If I could draw the abdominal walls on it, right, we would see that relationship there. I see that I am out of time, and I am out of slides. I do have some references that we'll include for you in the post-production that you can take a look at. Just a couple things there. There's a lot more that I didn't put in here. I hope that it's been, a little eye-opening, thinking of the relationships, thinking of the tools that we use in Polestar to assess. Everybody's different. And, we look at our best tool is our eyes to look and see if there's good dynamic alignment. If there's not in the movement that they choose to participate in, we can start going down and saying, is it an awareness problem? Is it a load problem? Is it a mobility problem? And as soon as we identify what it is, we have our marching papers. We know what to do. We're going to address that particular thing and see if that makes it better. And always, even if we increase the load tolerance or control and we increase the mobility, you still always have to lay more coordination on top of it. So coordination, coordination, coordination. And we look at the feedback. We talked about this a couple weeks ago. Internal feedback is going to be much longer lasting than external feedback. So we want to keep shifting as they progress into internal feedback. They need to be aware of that. I hope this helps. A lot more to come. If you have questions, send them to us. I want to thank both Melissa and Stephen for making this possible. We love sharing information with you. We have some great courses coming up. We'll share with you when the new scoliosis course is released. We still have some spots for the live critical reasoning course with me on the farm. I guarantee you, if you make the effort to be out here, I will make it worth your while. We're going to have live models. We're going to be working in very intimate groups to be able to really perfect our skills of assessing, problem solving, prescribing, and making a big difference. So I hope you'll join me. There's still time to get on the computer and make an airplane reservation. Come join us. We'll make sure that you have a very comfortable stay here on the farm. And we look forward to seeing you. Above all things, keep Turkey in mind, keep Syria in mind, keep those in New Zealand that suffered from floods in your mind. And above all things, be kind. And I will see you next week at another Polestar Pilates Hour.